Welcome to our live webcast, Advances in Neuromodulation, Spinal to Peripheral Applications. Thank you for joining us tonight. My name is Rene Przkora. I'm the Program Director and a faculty at the University of Florida in Gainesville, and I'll be serving as the moderator for this webinar. I'm also honored to be joined by our other speakers. This is going to be Dr. Yalamuru. She's practicing at the University of Virginia. And Dr. Prentiss Lawson, he's the Program Director of the Pain Medicine Fellowship at the University of Alabama in Birmingham, Department of Anesthesiology and Perioperative Medicine. And we'll be joined by Dr. Juan Mora, who's a faculty colleague with me here at the University of Florida in Gainesville, Pain Medicine and Anesthesiology. At the bottom of your screen, you'll notice the Q&A icon. So we would like to encourage you to submit your questions to our panelists using the Q&A icon. We will go to all three presentations tonight, and at the end of all presentations, we will review and answer the questions most likely live by our panelists. So please go ahead and submit your questions. Again, we're going to have a good discussion at the end of our webinar. And I would like to welcome Dr. Mora as our first speaker. And I see the screen is on, Juan, and we can see your presentation. So thank you very much for joining us. And
thank you so much, Dr. Przkora. Thank you so much, Dr. Przkora, for the introduction. Sorry, I was having a little bit of a technical things here, but welcome everyone. Welcome to this webinar series. I'm going to be opening this topic of discussion that is a really interesting topic, and it has made a lot of good advancements in the last decade. When I started on my fellowship, things were way different, and that has not been that long. I wish that, or I hope to think that I'm just not that old in this field, but things have evolving really rapidly, and every year pretty much we see a new advancement or a new way from this field. I hope as well that I'm not going to be taking too much out of the other speakers. And I just have nothing to disclose. As Dr. Przkora mentioned, I'm just part of the UF faculty here in Gainesville. So what is neuromodulation? So in a nutshell, it's just going to be an application of an electrical current to a nerve structure to obtain a desired effect. For our field, that is chronic pain management, is going to be hopefully to obtain that pain relief that we're looking for. Usually, most of this equipment, what they're going to have in common is that they're going to have a lead, which will contain some electrodes that is going to be connected either to an internal or to an external pulse generator. Usually, the external pulse generator can be for the trial phase, or as well for some of the temporary peripheral nerve devices. There's going to be different targets that we will be using for this neuromodulation for pain relief. The spinal cord stimulator, or the spinal cord, is going to be one of the most common targets that we're going to be using. But as well, we can target the dorsal root ganglion and as well the peripheral nerves. Usually, most of them will have a trial followed by a permanent placement of the device. There's going to be a couple of exceptions. There's going to be a temporary peripheral nerve system that does not require an implantation. And as well, the multifidus stimulator does not require a trial. The IPG is going to be implanted first. These devices are not new. These devices, the first case reports that we have is from the 1960s. And actually, they're pretty much at the similar time that they were reported the use of the PNS and SCS. PNS went first just by 1 year. Dr. Sheldon did a first case report on trigeminal neuralgia. And then the year later, Dr. Shealy did the first report on a spinal cord stimulator on a thoracic area with a paddle lead. Regarding the mechanism of action, historically, the main hypothesis that was circulating is going to be the gate theory by Wall or Melsack. This theory is still accepted, However, we understand now that is not the only one. So what this theory said is that everything in our nervous system is interconnected. There's going to be some different types of fibers. The fiber is going to be myelinated. They're going to be big. They're going to be the A fibers, right? And the A beta fibers are one of those that you will feel the proprioception. You will feel some tingling. You will feel some paresthesia and vibration. And when they are activated, actually, they can activate different receptors in our brain that they're not only going to conduct the signals, but as well they can inhibit other signals at the same time. The C fibers are going to be the ones conducting, they're going to be slow, they're going to be non-myelinated, and they're going to be responsible for most of our chronic pain patients, right? Remember, the A delta fibers are going to transmit that pain impulse really quickly, usually more for the acute pain, but the C fibers are the ones that are going to be for chronic pain mainly. So what the gate theory, what they propose, or what they were saying is that this large diameter sensory fibers, when they are speaking or when they're given some action potentials, they actually are the only ones speaking in the brain, and they can decrease the transmission of the C fibers. So if you see here, this will activate the inhibitory interneuron, and that inhibitory interneuron is just going to block the conduction of this C fibers. Even though the C fibers are present, this will the AB fibers will speak louder. This is the on the other hand, when the AB fibers are silent, or we don't have that the paresthesia feeling, or the AB fibers being stimulated, those inhibitory interneurons are going to be inactivated. Hence, the C fibers are going to be unopposed, and we're going to have a painful stimuli as a result. Now we understand that the gate theory is not the only hypothesis or not the only valid mechanism of action. We now, through molecular analysis, we know that there's going to be some more activation of other neurons. Actually, the wide dynamic range neurons are being widely studied for some of the specific waveforms for the spinal cord stimulation. As well, we know that the neuromodulation can facilitate the physiological inhibitory mechanism, and as well, it's going to change some of the neurotransmitters on our spinal cord. So it's going to stimulate the GABA molecules, as well as going to inhibit the glutamate, and it's going to stimulate or as well have an effect on the adenosine, acetylcholine, substance P, CGRP, BDNF, and the bradykinins. So definitely is going to be a lot of changes at the molecular level for the spinal cord. As well, the orthotomic activation of dorsal column fibers will activate or will modulate some of the serotonergic pathways. So it's not only the gate theory, it's just multiple mechanism of action for this neuromodulation mechanism of action. One of the basic things that we need to understand is that we are applying current to our body, right? And that current, how we are able to measure it or to program this is to understand what is the unit of or the metric that we need to know. So this is the waveform or the pulse, and the pulse is going to be given by different factors: the frequency, the amplitude, the pulse width, and the duty cycle. The frequency is going to be the number of pulses that you're going to give per second. You can give historically, for the tonic waveform, it was anywhere between 30, 40, up to 100. Usually you were trying to elicit a paresthesia feeling on the patient, but nowadays what we know is that we can go as high as 10,000 for a human application. That is going to be just oscillating super fast, that actually the patient will not feel the paresthesia. So frequency pretty much just tells us how often a neuron fires an action potential. Then, and this is just the frequency, right? How many times it oscillates in a second. Amplitude is going to be how big or how intense is that current delivered, right? So this is the amplitude, how big is going to be that pulse. It's going to be measured in milliamps, and it's going to give us the intensity. So that's why usually when you're programming the patient on a trial, then they're going to be increasing the amplitude to increase the intensity that the patient perceives that waveform. The pulse width, on the other hand, is going to be the duration of that pulse. and it's going to be measured in microseconds. This is going to be more about the spread of the stimulation. So sometimes the rep is reprogramming the patient on the spinal cord stimulation. If they're just mainly getting the right leg, they may just increase the pulse width to get maybe the left leg as well involved. So just to spread that stimulation. And the other one that is going to be important to understand is going to be the duty cycle. So that's going to be the amount of the on time. Nowadays, what we are trying to do is just not to fire high intensity and just fire like 24/7 electrical impulses to the spinal cord. But as well, we know that having a little bit of a rest period, it can decrease the tolerance or the habituation that some of the patients will develop. And this is given in percentage. So how much time on, how much time off is the waveform on or set up for this patient. Other basic concepts that we need to understand is going to be how is this energy being transmitted? It can be just transmitted by just only one electrode. So that's a unipolar way to deliver the energy. Or it's going to be given by two electrodes or a combination of two different or more electrodes. And that's going to be a bipolar. So the unipolar is going to be less precise. However, it can stimulate a larger area. Sometimes they're desirable. Maybe in the peripheral nerve systems, that could be actually something desirable because you can get more area, or maybe you can get a bigger fiber. But in the dorsal column or in the spinal cord, that may not be desirable because as well you have some motor fibers there, and it may be unpleasant for the patient. The bipolar is the setup that usually, or that nowadays we use for spinal cord stimulation, where the energy will travel from the cathode to the anode. So usually just travel from the negative to the positive loaded electrode. And it's a little bit more precise. It allow us to focus a little bit more on that sweet spot in that area that the patient is having the pain. Other concept is going to be that has been discussed recently is going to be the open versus the closed loop system. So the open loop systems has been the one that we have used for the past, well, since the invention of this. It's going to be a fixed output of energy based on program settings. It's just only one way. I'm just delivering it to you, to your spinal cord, but I'm just not really listening. The closed loop actually is measuring that in real time and adjusting that depending on the position of the patient, on the pressure of the patient sneezes, the patient do a Valsalva, and they can adjust how much you're giving to the patient depending on how much you are receiving. So it creates a closed loop. As well, the electrodes can come in a percutaneous lead, that is a cylindrical lead, that's usually the ones that the pain physicians do. Or it can be the paddle leads that is going to be a little bit more flat. It can have more rows of electrodes, and it may be and it could be less migration, but as well it's going to occupy a little bit more space on the central canal. One of the other things that are going to be basic before we start thinking about using this therapy, now that we can understand the concept and then our next speakers are going to go into detail on this spinal cord stimulation, DRG, and peripheral nerve stimulator, is going to be the patient selection. So one of the most important things to make this therapy successful is to select the right patient. If you only just go by the FDA label for this therapy, it may be a little bit just too wide, right? So that this therapy is approved by the spinal cord stimulation is approved for the management of chronic intractable pain in the trunk or limbs. As you can think, like pretty much involves everything. You just have to be mindful about a couple things. This patients that you're going to be implanting, unless it's a temporary device, you will develop a long-term relationship with this patient. You're going to do a surgical procedure on this patient, and the patient is going to be going through an advanced procedure with you and going to generate multiple visits that hopefully you're going to choose the right person to have a relationship with. In terms of the factors that will depend on the patient selection, well, it's going to be patient dependent and as well the pain condition. In terms of patient-related factors, psychological is one of the biggest ones. And that's why there's actually a requirement by the insurance companies for the patients to undergo a psychological evaluation. It is well known that the psychological issues, namely anxiety, depression, PTSD, borderline personality disorders, and substance abuse, are one of the main culprits for some of the loss of efficacy of this therapy. Remember that the therapy is not always successful. It does make a lot of advancements, but there's going to be still a lot of patients that are going to require an explant of these devices. For spinal cord stimulator, the most common reason for to have this device explanted is going to be the loss of efficacy first, followed by in the acute phase infection, and then migration as well of the leads, and then MRI need. That nowadays, luckily, most of these technologies are MRI compatible, so that has diminished the last one. Smoking, patients that smoke, actually, they may not be the right patient for this therapy. Smoking not only impede the wound healing and decrease regeneration, but it's as well a deleterious factor for oxygenation and neovascularization that you need for healing. It decreases the deposit of collagen, and just only by the patients smoking, then they increase their risk of having a new onset of pain in the limbs, right? So you're trying to control one of the pains, but then by smoking, they just come up with like new pains later down the road. One of the recommendations for our surgical colleagues is for the patients to stop smoking for at least 8 to 10 weeks. And that's usually what we have in our institution. We try not to do an SCS or a spinal cord stimulation or a DRG trial if the patient is still smoking, and they need to stop it for at least 8 to 10 weeks. In terms of glucose control, well, there have been some like SSI guidelines to try to decrease the surgical site infection percentage for this patient. The main recommendation, or the one that most guidelines will use, is to have a tight control of blood sugar around the procedure. You really need to go and aim for a blood sugar of less than 100 milligrams per deciliter. That's going to be the one that most commonly all of the guidelines will recommend to you. Some of them will tell you, okay, at least like less than 200, but usually 180 is a good target. In terms of A1C, there's not really a clear correlation. Some studies, or the primary care physicians will like for you, if you visit them, to be below 7%. However, there have been some studies that they have been comparing, like, okay, what if the patient is 8% of the A1C? If I go and make that a little bit lower for surgical site infection, and I see that there's no extra benefit to try to get them below 8%. And then just to keep in mind, the conversion of the A1C of 7% is an average of 150 milligrams per deciliter, and an A1C of 8% is an average of 180 milligrams per deciliter. So if you are 8 or below, then you should be okay. And that kind of like correlates with the guidelines for the blood sugar control that is less than 180 milligrams per deciliter. There's have been some recent data as well on on SCS for peripheral diabetic neuropathy. And in that randomized controlled trial, the inclusion criteria was for the A1C to be below 10%. And they were able to treat patients with that A1C elevated. If the patient has immunosuppression, consider to have a consultation with an ID specialist or rheumatology. If the patient is with a high MME or a high consumption of opioids, then there may be a risk for a failure for these therapies. There's going to be some hormonal and immune system dysfunction. They're going to be more linked with depression and weight gain, and as well with tolerance and hyperalgesia. Try to get your images, try to see the images before you implant the patient. There's going to be a lot of surprises that you just don't want to have a surprise at the moment of the procedure. You want to make sure that you can select the patients, that you have a central canal that is open for this therapy. Anticoagulation, just follow the ASRA guidelines. There's also an app. They're on the website. There's a document. So just please have them handy. In terms of platelet count for spinal cord stimulation, There have been like different discussions. This is an elective procedure. Some authors will recommend to have at least 80,000 of platelets, and some of the other studies have shown that maybe just 100,000, just because this is an ambulatory procedure. This is not an emergency like a C-section or so. So maybe you can just increase a little bit of that limit. In terms of the type of pain, spinal cord stimulation and neuromodulation works a little bit better for pain syndromes with neuropathic component. Given like radicular pain, motor neuropathies, CRPS, peripheral diabetic neuropathy. And it works as well for nociceptive pain, but usually when that is related with persistent spinal pain syndrome type 2. That's the one that used to be known as failed back surgical syndrome. So remember that now the new term is persistent spinal pain syndrome. And there are two types of that. Type 1 is the pain without surgery, and type 2 is pain after a surgical intervention. It seems that PSP type 2, it is a mixed type of pain. It's not only nociceptive, but it's actually just mixed a neuropathic with a nociceptive pain. The sooner you the sooner the patients have access to these therapies, the better they're going to do. If these therapies have been offered within the first 2 years of the onset of pain, then the success is dramatically better than if you wait for too long. And the same as well for the waiting time between the trial and the permanent placement. The sooner you make that switch, if a patient had a successful trial that is defined by having at least 50% relief, then the patient will do better with the permanent placement. Make sure that you understand the waveforms, make sure that you understand what each company will deliver, and so you can communicate with the patient. Not only just as well the waveforms, but as well how often do they need to charge, how big is the battery, are they MRI compatible, can they scuba dive, what steps do they have to do for an MRI, and if they are MRI compatible. There are going to be other indications for this therapy, so that are used a little bit more in other countries, but it's good to mention as well. So refractory angina, peripheral artery disease, painful diabetic neuropathy. This is FDA approved now for that, the spinal cord stimulation. HIV-related neuropathy, postherpetic neuralgia, phantom limb pain, spinal cord injury, visceral pain. Cancer-related pain when the patient has a higher life expectancy, or it has a slow disease progression, or there is an unexpected resolution of the disease. And now there's some new systems that as well, the indication is for axial low back pain secondary to multifidus atrophy. And as well, there's a recent FDA approval for some peripheral nervous system for occipital neuralgia as well. Thank you.
Mora, thank you very much for the lecture and the introduction to neuromodulation. And it's my pleasure to hand it over to Dr. Prentiss Lawson from UAB in Birmingham and his presentation.
Thank you, Dr. Przkora. One moment, group, is the share, for whatever reason, is not working for me right now. Bear with me momentarily.
No problem. No problem. Looks good. Very good.
You got it now? All right. Thank you, group. Sorry about that. So we're going to talk now more specifically in regards to peripheral nerve stimulation. There'll be a little bit of overlap just from the mechanism from the last talk. Thank you, Dr. Mora. And we'll focus a little bit more again on what we've observed with peripheral nerve stimulation itself. Only disclosures for me, I have given a paid CME talk on pain-related topics in the last 2 years, and I'm a paid medical advisor on a DoD-funded clinical trial. As far as off-label, my only mention here will be in regards to kind of observations and outcomes into off-label use of stimulation products. Learning objectives, so hopefully you'll be able to understand the various types of peripheral nerve stimulation and approach to therapy. and hopefully also appreciate indications, contraindications, and some of the outcomes associated with peripheral nerve stimulation. One of the things I really want you to kind of be able to understand, peripheral nerve stimulation, I feel like is really in its infancy. If you want to look at medical application of electricity, and if we want to go back to the torpedo fish with Scribonius, somewhat ancient in description of medical application of electricity, but really technology and engineering of the hardware that's able to deliver these waveforms in the peripheral nerve stimulation space in the last couple of decades really is what's allowed us to expand application and start to learn more. The first kind of more clinically useful peripheral nerve stimulators in the 1960s and 70s really involved a surgical dissection and cut down to a nerve and wrapping basically a wire with a fascial graft around the nerve. And back then, for obvious reasons, there were much more complications related to peripheral nerve stimulation. In the 80s, there was development of more of our modern neuromodulation devices, both leads and IPGs, but we really didn't see these kind of personalized peripheral nerve stimulation until, again, the last couple of decades. As batteries, IPGs became smaller, we had the invention of external batteries that are able to communicate with these internal devices, and then more lead designed applicable to these peripheral spaces. So really much more work is needed to be done when it comes to clinical application and understanding best waveforms, best patient characteristics when it comes to achieving the best outcomes from PNS. So again, exact mechanism of action from peripheral nerve stimulation is unknown, but it's thought that both central and peripheral mechanisms contribute. As was referenced before, the Melzack and Wall gate control theory is kind of the basis, again, for peripheral nerve stimulation in addition to spinal cord stimulation. And what's been observed in various animal and other studies in regards to peripheral nerve stimulation is that it decreases central sensitization and hyperalgesia. There's a reduction in excessive nociceptive activity at the spinal cord level. You also have inhibition of the wide dynamic range neurons in the dorsal horn of the spinal cord. Again, decreased A beta fiber-induced activity in the medial lemniscal pathway, and it may even affect the plasticity and NMDA pathways. There are various changes in cortical activity from peripheral nerve stimulation that have been observed. It may activate the dorsal lateral prefrontal cortex, somatosensory cortex, cingulate cortex, and parahippocampal areas. Additionally, it's been observed that there's reduced firing frequency from neurons in lamina 5 through 7 of the spinal cord. Certainly, neurochemically, it's been observed that serotonergic, GABAergic, and glycinergic pathways are involved with PNS analgesia. And again, there is disruption of transmission of nociceptive afferent fibers. Locally, the biochemistry is downregulated when it comes to neurotransmitters, endorphins, and local inflammatory mediators, as well as reduced ectopic discharge is demonstrated in electrophysiologic studies. Additionally, with the advent of some of the temporary percutaneous devices and observation of patients with prolonged relief after explant, there is a concept of peripheral reconditioning of the central nervous system that may be occurring, where but through remodeling of central plasticity and long-term changes, they're centrally induced by the peripheral stimulation, you may achieve long-term pain relief longer than the actual stimulation window. So what are the indications? There are various peripheral nerve stimulation devices, and you'll see their FDA labeling specific to those devices. But in general, you may see it utilized in acute pain for post-surgical pain after major surgeries like orthopedic surgery, post-traumatic acute pain, as well as post-traumatic chronic pain. In the chronic pain space, any chronic severe pain that has negatively affected function and has been refractory to other medical treatments, it involves one or two nerve targets based off of the technology and the stimulators being used. you may find an application in the chronic pain space. So that includes various peripheral neuropathic pain diagnoses, phantom limb pain, post-surgical neuropathies, occipital neuralgia and migraine headaches, hemiplegic shoulder pain and other chronic joint pain problems, complex regional pain syndrome, and chronic low back and neck pain. In most indications, with most devices, any craniofacial application tends to be an off-label use. Common targets you see listed here in the upper extremities, lower extremities, and abdomen and trunk. Again, conceptually, if what is driving the pain can be broken down into one or two targets from a nerve standpoint, there is a potential peripheral nerve stimulation application. Again, with much more work needed to be done to really tease out best chance for response when it comes to patient selection. Contraindications, so infection at the entry or target sites, obviously patient inability to manage a device. Coagulopathy tends to be a relative contraindication, because if you're in a site that is compressible, potentially that's not a contraindication to placement. MRI, again, depends on the device of compatibility, but definitely something that needs to be considered when considering patients and which particular device you may use with them. Pacemaker, ICD, deep brain stimulator status, again, probably depends on where you're placing this, how far away you are from that other device, but certainly needs to be considered and needs to be coordinated with those other providers managing those devices if you're considering placement. Risk, a lot of these are similar to peripheral nerve blocks from the standpoint of many of the current devices are placed percutaneously and then either buried surgically or in the case of the one available temporary stimulator placed percutaneously through a needle with lead externalization. So there's obviously risk of bleeding and infection if we're going through the skin. For percutaneous leads, there is a higher infection rate for non-coiled versus coiled leads. So for permanent devices in which a trial is done, you typically see a trial window that is similar to dorsal column stimulation, a 7 to 10 day trial. For the device that's manufactured to be applied for 60-day treatment window, it actually has a coiled structure that helps reduce the risk of infection. There's risk of nerve injury, obviously, but unlike peripheral nerve blocks, with most of these devices, you can actually be a little further away from the nerve and still capture with stimulation. Of course, there's risk of lead migration or fracture, device hardware failure, and even lead erosion, depending on how far under the skin you place it or where anatomically you place it. And then the risk of chronic insertion site pain. So this is a table. Actually, it's not as accurate as I'd like it to be. Taken from a review from a couple years ago, because one of the companies here actually doesn't exist or changed names. But I included this just to show the various characteristics of devices available on the market. So you see between the different devices, different lead design, number of contacts, whether they're single or dual lead configurations. You see permanent versus temporary percutaneous design, as well as differences in their MRI compatibility. So you really need to take this into account depending on which device you're considering to use and for which patients. Just a picture of some of the various devices. Again, the majority of these are designed with some degree of percutaneous placement with, again, if it's a permanent device, then you end up, tunneling and burying the rest of the device. You'll find many that have a small IPG that actually may have the battery component externalized that can communicate through the skin through typically RF radio frequency technology. The multifidus stimulator that you see on the top right somewhat different, as was referenced before. No trial. It's straight to a permanent implant. We'll talk about a little bit more about that in a moment. But design looks very much, closer to what everyone associates with neuromodulation from a spinal cord stimulation standpoint. This was again taken from that review from a couple of years ago. I included this methodology slide just to show that when it comes to the kind of study and data currently in regards to peripheral nerve stimulation, there are very few kind of randomized control trials. You can see this has increased in the last couple of years, but at the time of this review, 20 RCTs and 33 prospective trials that met inclusion criteria for this review. And then you can see the breakdown between the various parts on the body for application. So most of them with less than 10 studies at that point that met inclusion criteria. So very ripe area for study going forward. Looking specifically at some outcomes, so low back pain, peripheral field stimulation. There was a study that looked at 2 subcutaneous peripheral nerve stimulation leads in the area of pain plus optimal medical management versus optimal medical management alone, with the primary endpoint of being greater than 50% improvement at 6 months and 30% improvement at 9 months. There was a 33.9% response rate in the peripheral field stimulation group versus only 1.7% in the optimal medical management alone group. Also, when it came to sacroiliac joint application, there's a small retrospective case series that followed patients out to 4 years. And honestly, the follow-up at 4 years was a pretty low number of patients. But interestingly, again, from an observation standpoint, significant reductions in mean pain scores, going from a VAS of 8.8 to 2 at 1 year. And 2 of the 3 patients who implanted following up at 4 years reporting still to be satisfied with the degree of pain relief. Medial branch stimulation. So again, there are devices designed for permanent implant or temporary implant. This highlights a couple of studies in the temporary implant group. So a high quality prospective multi-center cohort of 60-day PNS of the medial branch nerves in patients who had undergone prior radiofrequency ablation showed that 67% of patients reported greater than 50% improvement in pain intensity, and 80%, 7% with greater than 50% improvement in reported disability. Effects persisted out to 5 months when 93% reported greater than 50% improvement for 1 or more of the outcomes. So again, that initial one was a pretty low patient enrollment as far as the numbers in the study, but since then, a similar prospective cohort by Gilmore showed greater than 50% reduction in pain intensity at 1 month and 12 months after PNS initiation. And later prospective multi-center clinical trial with much higher numbers, the N of 74 you see in that one, showing meaningful improvements for treatments of patients with chronic low back pain without radiculopathy when it came to average pain intensity, disability, or pain interference. And again, even though the treatment window was 60 days, at 3 months, 79%, at 8 months, 73%, at 11 months, 75%, and at 14 months, 77%, still showed meaningful improvement. Out of some of this temporary peripheral nerve stimulation data has come an interesting concept of delayed response. And so what's been observed with these 60-day treatments, there are certain patients who may actually not show a meaningful treatment response until about 4 weeks into the therapy. So it's just an interesting concept when we know that for other neuromodulation for permanent devices, typically because of infection risk, we're limited to a 7 to 10 day trial. It just from an academic standpoint makes you wonder, would there be potentially late responders in other areas? Medial branch stimulation from a multifidus stimulator standpoint is really thought to be kind of a restorative from a standpoint of rehabilitating the multifidus muscles. So there's a concept of atherogenic muscle inhibition that may occur after a back injury and a loss of neuromuscular control with patients. And so for patients who have evidence on MRI of multifidus wasting, as well as some physical exam signs that show potentially segmental multifidus dysfunction, this therapy may improve their back pain. Interestingly, the original study of reactivate or multifidus stimulation, the sham controlled trial did not actually reach its primary endpoint. So they looked at, we're looking for a 30% pain reduction in VAS at 120 days. And what they actually found was that for this therapy to be effective, you actually needed more time. So they've since reported 3-year and 5-year data that looks fairly stable, but this type of peripheral nerve stimulation actually needs time to strengthen the multifidus muscles. So it's a 20 hertz stimulation, strong multifidus contraction for 10 seconds, 2 times a minute. That's done for 2 30-minute sessions per day. So essentially working out those multifidus muscles, and it just takes time to respond. So again, at 1 year, 77% of patients in this study had a greater than 50% VAS reduction. 67% were thought to actually be chronic low back pain resolution responders. This was if their VAS came down to 2.5 or less. 63% had a reduction in their ODI greater than or equal to 20 points. And 71% of patients on opioids at baseline voluntarily discontinued or reduced use. And again, fairly stable report at 3 years and 5 years of these patients. When it comes to upper extremity, there has been some application in shoulder pain. This review just highlights a couple of short-term trials that showed some meaningful reduction in pain. I think that with the newer devices, it'd be interesting to see with longer, and there's some data coming out of the 60-day temporary application. But not only that, but some of the permanent devices, I think for cases like this hemiplegic shoulder pain, that will be an interesting area to kind of watch application. Brachioplexus disorders, peripheral neuropathies, complex regional pain syndrome. Again, most of the studies for these issues are small in nature and lack a lot of RCTs, but there are reports of meaningful pain reduction. The same when it comes to post-amputation pain and phantom limb pain. So you certainly can consider peripheral nerve stimulation for these. One thing I did want to mention that I kind of went past, but this particular Deer et al. Study, at 3 months, there was a 38% responder rate in the lower extremity treatment group. So, overall, there might have been a low responder rate, but clinically, when you see some of these patients, that may be very meaningful for the responders. So I just mentioned this to highlight we probably need to do more work on figuring out who exactly are the best indications and patient types to apply these different therapies. As I wrap up, I did want to mention quickly, again, you can find other nerve targets. Evidence is lacking, but when it comes to postoperative pain, there is some interesting data going back to 2017 for use for postoperative application when it came to orthopedic surgery. And so I expect the growing body of evidence to grow in this area as well. That being said, I'm going to just highlight the fact that the future is bright when it comes to finding more evidence and application for peripheral nerve stimulation. We definitely need to more data to standardize the patient selection, and maybe we'll even see novel applications. There's a lot of animal evidence that peripheral nerve stimulation may actually accelerate nerve regeneration after peripheral nerve injuries. So it'll be kind of interesting to see where these types of observations may lead in the future.
Thank you very much. I like the finishing. The future is bright. Yes, and I think we're having the experts and we can drive the field for our patients. And it's my pleasure again to introduce Dr. Yalamuru from the University of Virginia. She will be talking about spinal cord stimulation, so dorsal column and dorsal root ganglion stimulation. And I also saw already one question was answered in the Q&A feature. So again, if you have any questions, feel free, put them in there. We have one more presentation and then we'll be happy to review with the panel the questions you have.
Thank you, Rene. It's hard to follow in the wake of speakers like Dr. Mora and Dr. Lawson, but I will do my best. I'm going to go over spinal cord stimulation and dorsal root ganglion stimulation. We'll talk about indications and technique. I've talked a little bit about the outcomes while we're talking about the indications itself. In the interest of time, I have no conflicts of interest to disclose. The only off-label or things I will be referencing are SCS for angina pectoris and peripheral vascular disease. It's not FDA approved in the United States for these indications. However, it is extensively used in Europe. We will go over the indications for spinal cord stimulation and the supportive evidence for this, indications for DRG stimulation, and a brief overview of the technique for placement of spinal cord stimulator leads and dorsal root ganglion stimulator leads. So primarily, the indications for spinal cord stimulation are for persistent spinal pain syndrome. In the past, it was referred to as failed back surgical syndrome. We have a growing body of evidence to use it for painful diabetic peripheral neuropathy now, as well as complex regional pain syndrome, for which there's been evidence for several years now, angina pectoris, and peripheral vascular disease. And we'll talk about each one of these in some detail. So in patients with persistent spinal pain syndrome, spinal cord stimulation has shown significant long-term relief, decreased medication use, improved functional capacity, quality of life, and the likelihood of returning to work, and has minimal side effects in comparison with other treatments. And some of this evidence comes from some of the literature by North et al., who compared laminectomy versus spinal cord stimulation and found that over 47% of patients with spinal cord stimulation had over 50% of pain relief in comparison with less than 12% of the laminectomy patients. There were other studies that compared patients with failed back surgical syndrome or persistent spinal pain syndrome who underwent spinal cord stimulation versus conventional medical management alone, and showed, again, over 50% reduction in almost 48% of these patients. Another study that I would recommend looking into is also the process study, which looked at these outcomes again. In addition to radicular pain and lower back pain, over the years, we've had, changes to waveforms. And with the introduction of high frequency 10,000 kilohertz spinal cord stimulation, there was an increasing application of using it to patients with axial low back pain. And in the Senza randomized control trial, they found that, there was the primary endpoint was over 50% reduction in back pain. At 3 months and 12 months, they found that it was attained with high-frequency spinal cord stimulation as opposed to conventional spinal cord stimulation. And they also had good outcomes for leg pain reduction. However, with that, it was increasingly used also for axial back pain. For the other indication, which it's commonly used for, complex regional pain syndrome, there's been evidence over the years for this. However, some of the literature that we have does have a smaller number of patients as compared to other studies that looked at back and leg pain and post-surgical spinal pain. And then they showed improvements in pain control with spinal cord stimulation versus physical therapy in this study with Kemmler et al. And overall, in multiple studies that looked at spinal cord stimulation for patients with CRPS. It is a great level A recommendation, but they do acknowledge that the amount of research is limited in this category with regards to this. Angina pectoris is one of the leading indications for spinal cord implantation outside of the United States and Europe. And it has been found that spinal cord stimulation can improve circulation, it can decrease anginal attacks and nitrate requirements, it improves patients' exercise capacity, and also has been effectively used to treat intractable angina and decrease the incidence of anginal attacks, and has really good cardiovascular outcomes. Again, this is not an indication for which we use it in the United States. In Europe, there's pretty good, it's used more extensively for peripheral vascular disease than it is here. And this was a really good meta-analysis where they looked at 9 studies with 444 patients who had peripheral vascular disease, and found that those who undergo spinal cord stimulation therapy have a lesser risk of having a limb amputation than those who undergo conservative therapy alone. It improves tissue oxygenation, and they noted that was pretty significant with SCS therapy. And the limb salvage rate was about 83% with spinal cord stimulation. There are other studies that have not been since able to replicate the risk, the significant decrease in risk to limb amputation. The more recent indication for which it's been used is painful peripheral diabetic neuropathy. And this was following a study by Dr. Peterson et al. It was a multi-center randomized control trial that they looked at 10,000 kilohertz spinal cord stimulation for peripheral diabetic peripheral neuropathy. And they compared it to conventional medical management. And currently, 10,000 kilohertz spinal cord stimulation is the only FDA-approved neuromodulation therapy for painful diabetic peripheral neuropathy. Knowing all these, what does CMS actually cover? So if you look at those indications, it's for chronic intractable pain of the trunk and limbs, post-laminectomy syndrome, or persistent spinal pain syndrome. It does cover for complex regional back syndrome, pain syndrome. It covers chronic refractory non-surgical back pain, painful diabetic peripheral neuropathy, post-herpetic neuralgia, and lumbosacral arachnoiditis, which is refractory to medical management. Moving over to dorsal root ganglion stimulation. It is basically different from spinal cord stimulation in that you are obtaining percutaneous epidural access, and you are guiding the lead towards the neural foramen in the dorsal root ganglia as opposed to leaving it in the midline in the epidural space. It can target lumbar and sacral nerve roots, and the proximity of the leads to the DRG results in lower energy requirements, and there's less postural change, so there's improved outcomes with this. The indications for dorsal root ganglion stimulation are for patients who have complex regional pain syndrome, whether it's type 1 or 2, patients with post-hernia repair pain. It's also indicated for diabetic peripheral neuropathy, chronic post-operative surgical pain, whether that's in the knee or the hip, neuropathic groin pain and pelvic pain, phantom limb pain, and post-herpetic neuralgia. So with dorsal root ganglion stimulation, it's important to know that the target levels vary depending on where the pain is. Typically, leads are placed at T12 if the pain is in the abdomen and groin. L1 for patients that have hip, waist, or groin pain. L2 is for upper leg and groin. L3 is for knee and leg. L4 is for the ankle. L5 is for the foot and lower leg. S1 is for the foot. And if you're doing for pelvic pain, leads are placed both at L1 and S2. Now for an overview of the technique for an SCS trial and an implant. The important first thing is when you take the patient in, making sure the patient appropriately positioned, you have good imaging. And for spinal cord stimulation, and for dorsal root ganglion stimulation, there's a trial period and an implantation period. The main difference with a trial and an implantation is with a trial, it's just percutaneous access, you leave the leads out, connecting to the IPG external pulse generator in this case. And with an implant, there's a cut down to the fascial plane, you're anchoring the leads, you create an IPG pocket, and you have to tunnel the track to the midline incision. It requires more surgical skill. There's different kinds of SCS implants. There's percutaneous leads and paddle lead placement. Typically, as interventional pain physicians, we're all doing percutaneous lead placements, not paddle leads. The important thing in this is making sure that you have good epidural access and entry. So obtaining good imaging, identifying the point of epidural entry, make sure that you're moving from paramedian to midline. And typically you start at a pedicle below for smaller patients, this green mark, the light green, and then slightly lower for medium-sized patients. And for patients with a larger habitus, you start 2 pedicles or lower, primarily to ensure that you have a shallow enough access point and you're not steep, to ensure that your leads remain posterior in the epidural space. It involves, after obtaining imaging, oftentimes using 22-gauge spinal needle to determine the angulation depth, create a tract of local anesthesia, also provides good procedural comfort. It helps you understand if you need a longer needle and what your approach should be. Typically, a 14-gauge 2He is used to access the epidural space, and using multiplanar fluoroscopy, using AP, contralateral, oblique, and lateral views, the epidural space is accessed using a loss of resistance technique. And there's significant practitioner variability in it. Some use only saline or air. You can also use a lead blank to enter. And if you're going to use contrast, ensure that you're not using too much. Most practitioners, I think, avoid using contrast in this situation. Once you do obtain access, then the leads are threaded in and guided in to the target locations. Cephalad, this is done using AP imaging, and the lateral views are used to confirm and make sure that you're posterior enough in the epidural space, you're not ventral. And once appropriate location is reached, the testing is done to ensure that you have coverage of the required painful areas. The leads are adjusted as required. And once you're happy with that, the needles are retracted slowly, and the leads can be anchored to the skin with an adhesive. Now, when a permanent implant is being placed, it can be done either similar to the trial or through the fascia after the skin is cut down initially. The differences are with, if it's percutaneous, you're not making the incision until your leads are in the place, and but the incision can be less linear. You can make a smaller incision if required. Whereas when you're doing a cut down with the fascia, you have to plan appropriately ahead of time. And you can typically sedate the patient during the process of the cut down and until you actually deploy the leads. And the wound is usually larger with this. The leads should be anchored over the fascia and sutured in to ensure that the leads stay intact and the risk of migration is lower. After which they're tunneled into the IPG pocket. The IPG pocket is typically created between in the flank between the 12th rib and the iliac crest. You identify it before taking the patient into the operating room based on patient's comfort. It's often marked ahead. And after making the incision, you use a combination of sharp and blunt dissection to create that pocket and create a tunnel to the site of lead insertion and tunnel them. It's important to create some strain relief loops while you're doing this. Irrigate the wounds well with saline. Occasionally, you can cover it with like an antibiotic pocket as well before you close the incision. And multi-layer closure is recommended for this. And once you're done closing the wound, place a sterile occlusive dressing over the wound. So we do have some really good recommendations on what is good technique for implanting spinal cord stimulation and the neuromodulation appropriateness consensus. The NAC committee recommendations are really good. With regards to sedation, they do say that the lead placement should occur when the patient is awake enough and alert enough to provide necessary feedback, report what they're experiencing, whether in terms of pain or paresthesias. If deep sedation or it's being done on general anesthesia, neuromonitoring is recommended. They do recommend using non-absorbable sutures when it comes to anchoring leads and using mechanical anchor devices to anchor the leads. For wound closure, the recommended practices have grade 1 evidence are a sterile saline irrigation and hemostasis before closure, avoidance of excessive cautery and soft tissue trauma before closure, and use a multi-layer closure to reduce dead space and infections. It's a level 2 recommendation for the use of occlusive dressings over trials and implants for 1 to 2 days. The DRG requires slightly different equipment, and the sheath, in addition to an epidural needle, you do require a delivery sheath, which is stiff, which helps you deliver the lead to the target DRG, and it often has a side port and a guide wire as well. The lead has a stylet which is already implanted in it. And this is just a nice picture of that. It's important to set yourself up for success when you're doing a DRG implant, and important to align your target vertebral bodies and plates really nicely, center the spinous process, and have good imaging before you even start the process. Marking and identifying your entry points is also important. There's different approaches to DRG lead placement. They include contralateral approaches, ipsilateral approaches, and even retrograde. I'm just going to go over quickly the contralateral approach, where you use the contralateral pedicle below the target level and enter the epidural space. And the recommended access points, if you're doing L3 and above, is to use a contralateral pedicle 2 levels below the target epidural space. And if you're doing L4 and 5, at the junction of the SI joint and S1 and 2 is the recommended entry point. Whereas for sacral leads, you enter it directly above the foraminal opening. This kind of gives you a nice diagram where if you're entering at L3, you typically go on the contralateral side, 2.5 pedicles below. And this is your target point where you're going to be entering to get to the L3 for foramen. And point C is that foramen where you're entering. So you kind of draw a line connecting these three before you even start. Once you have it, kind of gives you a pathway to enter. You numb the skin, you access the epidural space. Ensure that you're entering the epidural space in the upper half of the interlaminar space, that you're entering it at the midline. This will make it easier when you're trying to drive your sheath and your lead to the target pedicle. The sheath is curved distally, and it helps with directing the sheath to your target location. you have to ensure that your bevel and your sheath are aligned before you start advancing the sheath. This is another fluoroscopic image of what a good trajectory should be if you're assuming that this is the target DRG, this is where you want to enter the epidural space, and 0.3 is where you enter from the skin. And this is the diagrammatic representation of ensuring that you are in the superior part of that interlaminar space to enter with your tuhi, so the sheath and lead can be directed towards the target DRG. It often takes maneuvering and very gentle repeated tries to ensure that your sheath can make it into the foramen as it traverses through those ligaments in the foramen. And it takes practice. Once you do get there and you deploy the leads, the next step is ensuring that you're creating loops, strain relief loops, to ensure that these leads stay in place. To do that, once your leads are deployed, you retract the stylet from the tip of the lead, and you rotate the needle in the sheath away. And then you gently advance the lead and the sheath in combination into the epidural space. Or you can feed the lead just into the epidural space. Ideally, you want to create either an S or an M kind of loop here in the epidural space to ensure that it has good strain relief. And this is what it looks like on the lateral view when you have the lead that's in and then a strain relief loop. And then you ensure that you confirm the lead position both on AP and lateral imaging to ensure that it is in the foramen, and anchor the leads in place. In the past, anchoring was not done. That led to increased risk of lead fracture and lead migration, which you can now avoid with anchoring the leads. And I'm hoping I'm really not too much over time now.
Bhavana, this was excellent. Thank you very much for the overview. I think we're good on time. And I know we had a few questions in the Q&A feature which have been answered. So I appreciate those. And I don't see any new questions coming in. So I'll say I'm going once, I'm going twice, and then I think we have concluded this webcast. And it's, again, my pleasure on behalf of Ezra Pain Medicine and the Association of Pain Program Directors. I would like to thank you for participating tonight. Especially would like to thank our speakers. And I would like to highlight that the next Ezra Pain Medicine APPD Hot Topics webinar will take place on April 1. Again, please mark down April 1. And we will focus on building a future practice, strategic planning, contract negotiations, and achieving success. We hope to see you then. Thank you and have a pleasant evening.